In the majority of patients in the intensive care unit, we have a presumptive diagnosis of sepsis, but we often can't identify the specific organism. We therefore have to choose antibiotics based on our best guess. Procalcitonin is a biomarker that will help us assess whether we are getting an appropriate response to therapy in an individual patient. By looking at the kinetics of procalcitonin's decline, which is typically about 50% per day, we can see an adequate response to therapy. If the levels do not decline or in fact increase, then we either have the wrong organism, a protected site, or the wrong antibiotic. Patients who present with sepsis and septic shock are a very heterogeneous group. They vary in age, they vary in comorbidities. Prognosticating becomes difficult based on standard evaluations at the bedside and standard laboratory data. But it's important to be able to stratify these patients for risk for mortality and the likelihood of recovery. Procalcitonin has been demonstrated in the MOSES trial to do both these things. An initial level greater than 2 has been associated with an increased risk for mortality, and that can be determined as soon as the patient presents to the intensive care unit or even before in the emergency department. And then if we follow serial measurements and we look at the 4th day, a reduction on day 4 of 80% from the peak level of procalcitonin suggests a significant improvement in likelihood of good outcome. And if it does not fall by 80%, then the mortality rate is estimated to be twice as high. When we look at the available biomarkers for identification and management of patients with infections, there are many. Most of them work hand in hand together and give us useful information, not necessarily the same information. For instance, one of the more commonly used biomarkers in sepsis is lactate levels. Lactate levels are all about perfusion. They tell you whether the patient has been adequately resuscitated. They do not tell you, however, whether the patient has been given adequate therapy for the underlying illness. Procalcitonin is a very specific biomarker for bacterial infections. It won't be elevated in viral infections, and aside from candidal infections, it won't be elevated in patients with fungal infections either. We do have other biomarkers like IL-6. It's a rather evanescent biomarker. It is released very early in the onset of infection, often disappearing before the patient will present to the emergency department or even realize how sick the patient might be. Finally, we have C-reactive protein, which is also an excellent biomarker for bacterial infections, but it's looking at a different aspect. Whereas procalcitonin is looking at the interaction between the bacterial infection and the host, CRP is actually looking at the response and the destruction associated with the bacterial infection, that is the inflammation. And CRP, therefore, is not as specific as procalcitonin would be. Typically in the winter, we have lots of patients with chronic lung injuries that present to the emergency department with various levels of dyspnea and shortness of breath. We had a patient just recently who had a long history of chronic obstructive lung disease, presented with about a 2 or 3 day history of shortness of breath, some wheezing, cough. The sputum was a bit purulent. He was quite short of breath, though, unable to walk more than 5 or 10 feet before he got breathless. He was found in the emergency room to be in ventilatory failure. He had a very high level of PCO2 and was admitted to the intensive care unit for monitoring of his ventilatory failure. Of course, one of the considerations was whether this was induced by a respiratory infection. So a white count was done. The white count was a bit elevated. There was a bit of a left shift, but the patient was stressed. His PCO2 was high. His pH was very low. So procalcitonin was drawn in the emergency department, and we got a rapid response, and it was about less than 0.1. Patient was brought up to the intensive care unit, started on antibiotics, however, in the emergency department. And now the patient's in the intensive care unit. He's receiving non-invasive positive pressure ventilation. He seems to be doing quite well, got some fluid resuscitation, bronchodilators. The next morning, we repeat his laboratory data. The white count that was elevated in the emergency room the day before is now normal. The left shift has normalized. His PCO2, fortunately, has responded very nicely to the non-invasive ventilation. And the follow-up procalcitonin, done just about 24 hours after the initial one, is also less than 0.1. Well, in this case, that would demonstrate a very low risk for bacterial infection, and so we were able to addend the therapy appropriately to meet this patient's need. I'm a disciple of Roger Bone, and he, as a mentor, pointed out to me that not every patient in the intensive care unit who looks like they're infected are infected. And some patients who are in the ICU who don't look infected are in fact infected. And we had always searched for a more specific biomarker to identify patients who might have bacterial infections. It became obvious to us that the white cell count, the bandemia, and lactate levels were not those markers. Certainly fever curves were not very useful either, since 2/3 of my patients in the ICU have fevers, but only about 20 or 25% of them are infectious. Procalcitonin was the first biomarker that we were able to use at the bedside that gave us very clinically useful information, helping us to identify the presence of bacterial infections, and when the levels were negative, to indicate that there was a very, very low risk for bacterial infection.